Welcome to the March edition of the Urology Journal Club podcast. 4 articles today. I've been increasingly using the World Journal of Urology. The quality of the papers there and the volume of the papers there seems to have increased in the last few years, and I'm enjoying that journal. The first one relates to a non-randomized trial comparing prostate artery embolization with holmium laser prostates for very big prostates, those between 80 and 250 grams due to BPE. They had about 45 patients in the study, and they obviously looked at things like voiding parameters, sexual function, complications at 1, 3, 6, and all the way up to 12 months using obvious scoring systems. And I must say the findings from this trial were kind of surprising to me. They showed that there was no significant difference between the IPSS score and the quality of life between PAE and holmium. So similar improvement in symptom score. The PAE had, as you might expect, improvement in incontinence scores and in erectile dysfunction scores compared with HoLEP at 1 and 3 months. However, HoLEP did outperform in terms of PSA reduction, Qmax, and post-void residual at 3 and 12 months. PAE, as might be expected, had a short hospital stay and avoided catheterization in most patients. So for me, this is a surprising study demonstrating almost equivalence, seemingly, between HoLEP and PAE, and particularly in the domains of sexual function, incontinence, and similar findings with IPSS scores and quality of life. So PAE unexpectedly seems to be scoring very well here, and I think this is an important paper. Perhaps does need correlation with bigger numbers, but something to take note of. Switching now to pediatric urology, and this is a paper looking at the use of intravesical oxybutynin for bladder capacity in children with myelomeningocele. This is a French multi-center randomized trial, and this is something that we've been peripherally involved in looking at. We know that the side effects of oxybutynin, particularly in the pediatric population, to do with cognitive issues, constipation, etc., is quite marked, and the attractive idea of avoiding the first pass by putting the oxybutynin into the bladder has been something that we've looked at. We've had contact with the International Spina Bifida Association, whose headquarters are in Belgium, and they've certainly been promoting its use in, let us say, developing countries, and they advocate a simple method of crushing the oral tablet, putting into 5 ml of boiled cooled water, and then instilling it after CIC is performed and leaving it in the bladder until the next time. There have been some literature reviews that have looked at lower quality evidence, and they did show improved bladder compliance and reduced pressures with intravesical oxybutynin. However, the level of evidence has not been sufficient to change practice or make its way firmly into the guidelines. We know that there's a stepwise treatment managing these children with catheterization, cholinergics, perhaps the use of Botox, and finally surgery. And obviously, Botox has its problems in that it only lasts about 9 months and also requires repeated general anesthetic in these children. Anyway, what did this study find? Well, the answer is we don't know yet. It really is an article that I saw in the British Journal, and it's in fact a study protocol paper. So they've set out the protocol, and I think we should probably have results from this trial in the next couple of years. But I think an important thing to be looking at as an alternative to the use of oxybutynin. The third paper also comes from the British Journal, and an interesting clinical question. They're looking at how prostate zonal anatomy might change related to finasteride use, and this is using multiparametric MRI. This paper comes on the back, obviously, the prostate cancer prevention trials, where there were the 2 big trials using finasteride and dutasteride to see if that could be chemopreventive agent. And of course, we know that it did reduce the incidence of prostate cancer, but unsettlingly it increased the number of clinically significant cancers, and therefore it's never really found its way into conventional practice. So this paper, they retrospectively looked at close to 700 patients who'd had an MRI targeted biopsy, and there was a subset of around 60 patients who were receiving 5-alpha reductase inhibitor therapy for LUTs. The results here were, interestingly, that the 5-alpha reductase was associated with significantly reduced odds of detecting clinically significant cancer in the targeted biopsy area. And stratified analysis revealed a pronounced reduction in clinically significant prostate cancer detection in peripheral zone lesions, but not in transitional zone lesions. So what are we to make of this? Well, the authors concluded that treatment with 5-alpha reductase was associated with decreased clinically significant on targeted biopsy, especially in the peripheral zone. And they make the point that perhaps patients on 5-alpha reductase, we should consider that they have the potential for increase in false positive MRI findings. So, interesting to consider that 5-alpha reductase may change the characteristics MRI interpretation of prostate, which may lead to increase in false positives for these patients. The fourth paper comes again from the World Journal, and this is a multi-author, multi-institutional trial from Europe, and looking at the outcomes of BCG unresponsive therapy for non-muscle invasive disease. So we know that BCG unresponsive patients face a high risk of disease progression. Typically, radical cystectomy is the recommended standard of care, but many of these patients are unfit and a proportion of them unwilling to undergo radical surgery. So what is to be done? Are there any bladder-sparing strategies which might be helpful in that setting? And the two additional groups that they looked at were those who received gemcitabine, docetaxel combination intravesically, or hypothermic mitomycin, or so-called electromotive drug administration of mitomycin C. And they had two other categories, with those patients who received further BCG and those who received upfront cystectomy. And I think the results of this trial will interest you. They had 360 patients in the trial, and the 2-year risk of disease progression was 15% for gem and dosi, 20% for hypothermic mitomycin, and 30%, so increased percent, with BCG. When they looked at multivariate analysis, they showed that there was a lower risk of progression compared to further BCG, with a significant hazard ratio of 0.19. The 2-year cancer-specific mortality, this is of importance. So cancer-specific mortality in these groups was 0% if you received the other intravesical options, 4% for BCG, and interestingly, 7% for radical cystectomy. So I think that's quite an interesting finding, albeit that 2-year cancer-specific mortality is a relatively early marker. But clearly, there are patients who've then gone on to have radical cystectomies who have got morbidity and potentially mortality from that treatment. So they conclude that in real-world practice, gemcitabine, docetaxel, and hypothermic mitomycin represent viable options for bladder sparing compared with radical cystectomy or further BCG. So I think this could be a practice-changing option, and I want to thank you for your attention and look forward to seeing you again in April.